Sure, no problem.
You know what happens, Dr. Sujana? A lot of people, they're all finishing with work, end of the day. And
Yes.
even myself, I just reached reached home 10 minutes ago and I quickly changed. So
Yeah.
there would be a lot of people who log in around 7:10,
Okay.
if that's
Okay.
okay with you.
Oh, of course. Of course.
Yeah. Yeah. Thank you.
Yeah. It's Zoom stuff is wonderful and it's also terrible because then you never get to just go home and be home. But it's so nice to be able to talk with you and your group today. I mean, this is amazing, right? Amazing technology.
Thank you, my dear. I mean, we don't mind even international members could join our forum because it's a purely academic society. Our
Mhm.
focus is purely on academics and also to, of course, help our juniors,
Uh-huh.
resident doctors, as well as people who are interested in pursuing this subject. So we want to help them, help them procure instruments, guide them, be their mentors, suggest few fellowships for them. So in whatever way we can help them. And ongoing lectures like this. And we also conduct quiz programs now and then. We've had 2 national conferences already. So, I mean, anyone is welcome to join, anyone, even outside India.
Wonderful.
Thank you.
When
So we are a 5-member executive. Sorry, go ahead.
no, go ahead, tell me.
So, yeah, so all of us are striving hard to do our best, keep everyone on their toes and, meaningful interactions. And we almost have case discussions also almost every day on the group, WhatsApp group. So there are about 1,700 members, and if there's a difficult case, somebody would post it, and then everyone's opinion starts coming up. So it's like a interactive platform, and I'm sure it's useful for most people.
Yeah.
So yeah, so it's a totally apolitical organization, and the only goal is to reach out to everyone and pick up talent. There are a lot of talented people in our society. Some of them have not presented enough, like usually what happens in most organizations is the same set of speakers that come up. And the intention of WI is to even bring new talent to the forefront. And let's see how it goes. It's a very nascent organization.
So, I think that problem of the same speakers and nobody else getting a chance is worldwide. And we started the Women in Otolaryngology section. It started as a committee and then it became a section with its governance at the American Academy of Otolaryngology in 2010. And us being there has been very important, not just for women, but for the entire academy, because voices, as you said, who previously were not heard, are now heard. And ideas are shared. It's really, really very positive for all of our membership and all of our patients.
Yep. We're going to take more advice from you too, because you've already had the experience of running such a big academy.
Yeah, it's a lot of
really
fun.
Proud of your work.
Thank you.
Yeah. In fact, you have a very long CV. So what we have been doing is we've been rotating this amongst all the members since yesterday, multiple times posting, so that we don't take enough time now to read out your entire CV because everybody has gone through it already in print.
Well, thank you. That's very nice.
It's our pleasure. So it's 7:02. There are more than 40 members. We'll give it another 5 minutes and we're set to go.
So I'll tell you, one of the ways to ensure new faces and new voices is to encourage ourselves and our male colleagues to be very intentional in the makeup of panels and conferences. So, you know, in the American Otological Society and Neurological Society, we actually have in our bylaws that the panels must be diverse in many ways. And I think that's very, very important, so that you're not hearing the same old over and over again, but you're hearing new ideas, or maybe old ideas said by new people to show that those ideas are still meaningful.
Very true. I completely agree with that. So I think we're on similar lines, but I really appreciate that you have been holding so many posts, you know, one after another, one after another. I'm sure it has been, I mean, you were already multitasking. I'm sure you were taking care of your family throughout, you know, all this while, apart from being so busy with your profession. So all of us are lucky, you know, we want to know more of you. I mean it. So now I think it's about 7:04. Another minute we will start. Ashima, how many participants?
Ma'am, we have 64 logins as of now.
Wonderful. So I think we should start, because punctuality also is one thing we've always been following.
Do you want me to just start?
No. I'll be giving you, there'll be a brief introduction for sure. We have to welcome you, my dear. So good evening all, good evening WAOI members. It's the pleasure of WAOI Executive to bring in another international speaker for this month. She's Dr. Sujana Chandrashekhar. Please give a huge round of applause for her. So since it's online, I don't think we can hear an applause at the moment. But well, her introduction, you know, it's very unfair to introduce her in 2 minutes. So I'll be very brief. And she's got a very long CV, and I'm sure all of you have read it on the group. And she's an otolaryngologist like us, but subspecialized in otology and neurotology. Dr. Sujana, we have a lot of otologists in this group. So we have a lot of cochlear implant surgeons also in this group. So I'm sure they're all keen to listen to your talk. So Dr. Sujana has been involved in patient care and teaching and humanitarian work and mentoring. So she's been teacher to many, actually. She's been teaching residents actually from 6 different ENT programs. Can you believe that? So excellent teacher and a co-executive producer and a co-host of a popular video stream show. Wow. So you must be really popular since you're on a video live stream show. So how nice is that? So is this a weekly show? We'll ask you at the end. And the name of the show is like She's on Call. So she's also a consulting editor of OCNA. Now, OCNA, I mean, I've always felt this is one of the best journals. OCNA is the best. And so she's been a consulting editor, for which she has been instituting various podcasts for each issue. And she's the president of American Otological Society. Earlier, she was the president of, a big American Academy of Otolaryngology Head and Neck Surgery, which consisted of 13,000 members. She was previously secretary treasurer before taking up the president post for American Otological Society. And there's much more. And thanks a lot, Dr. Sujana. You know, it's hard to find time, you know, especially with the time difference. We're in different zones, and really I appreciate that you're taking out time during work for us. Now, she's already seen a lot of patients in the OPD, and she's taken a break especially for us. All of us are really very, very thankful. You're welcome, Dr. Sujana, and we're proud to know you. Please start.
Thank you. Thank you so much.
Thank you.
I really appreciate the warm welcome. I very much appreciate that you reached out. It's nice to be home, even if it's only by Zoom. So I'm a simple girl from Bangalore and or Bengaluru, and only been in the US since I was 5, so just yesterday, and very much this is one of my passion areas. I love all the work that I've done that you described, but my very first foray into research in otolaryngology was working with my father, Dr. Chandrashekhar, who's listed there. He trained, he was a student at Mysore Medical College and then worked in Bangalore, and then went on to do his FRCS in Edinburgh, went back to Bangalore, and then we all came to the United States because my mother, who is MRCP, got a fellowship in adolescent medicine at what is now Children's National Medical Center. So my parents, my sister and I came, and we have settled in the United States since 1969. So the clever ones of you know exactly how old I am now. Built a very nice life here, but really love learning about the temporal bone. So let me talk to you about this. I've been given about 30 minutes to do some hard science, and then I'm willing to take any questions you like to ask me. Okay, so now, okay. So when you think about looking at the temporal bone, there are reasons to do so, right? So the reason to do so is that we can understand a great deal of what's going on, what had gone on in the patient's life, what caused the dizziness or hearing loss, what systemic illnesses caused the problem, by looking at very thin sections of the temporal bone. In real life, we rely a great deal not only on clinical judgment, but on radiography, on CT imaging. So my goal for this presentation is to combine the more detailed information you get on histology slides with the thicker but more commonly seen CT images. So first, you harvest the temporal bone, and it's outlined here. You try to harvest it within 24 hours of the patient's demise. You fix it in formaldehyde, you decalcify it with a certain type of acid, and then you embed it in a colloidin so that you can cut it. So you have to make the bone, you have to decalcify the bone and then set it so that it doesn't fall apart. And the sections are 20 micron thick sections, and you stain every 10th section and hold the other 9 in abeyance so that if you need to do different types of staining or different types of looking, you can do so. And this actually was very helpful to us when we studied. My father and Veronica Siverls, his assistant, and Dr. Mishislava Sachs, who was his other assistant, published the seminal piece on rubella and on fetal temporal bone anomalies with rubella. And I don't know what's happening in India, but in the United States and elsewhere, we're seeing a lot of this growing movement to avoid vaccination. So I'm quite afraid that what I thought was old may become new again. We also found this to be very useful looking at the temporal bones of patients who are afflicted with HIV disease. And we were actually able to identify viral particles in the endolymph in patients with HIV disease, which is very unusual. You normally don't see it penetrating the endolymph. So normally we look at a CT scan. A CT image is about 1 millimeter thick, sometimes 1.5 millimeters thick, whereas the matching horizontal section or axial section is about 20 microns thick. So I often do this as sort of an interactive exercise, but because I can't, I'm just going to do this as a teaching exercise, and I won't put anybody to shame trying to get you to name structures. I will tell you that a lot of this and sort of even better pictures are in the temporal bone histology and radiology atlas that my father and I published with Plural Publishing in 2018. So it is a self-directed book. So you'll see one page like this, and then the next page will have the structures labeled. If you're interested, I think it's a wonderful resource. It's based on the course he taught at the Academy for many years, and then I came on with him. So here you see sort of the highest level horizontal cut of the histology, axial cut of the CT image, and you're seeing some structures that are being pointed out here. And if you think about, what is, can you see my arrow when I move it like this? Okay, so if I'm looking at this, it is the same as this. It happens that this is pneumatized and has some marrow bone in it, and this does not, but that's the same structure. If you're looking at this structure, it's the same as this structure. If you're looking at this structure, it's the same as this structure here. So when you see what these structures are, this is the petrous apex. And when it has marrow in it, when it is full of marrow, it can look bright like fat. So on an MRI scan, between T1 and T2, fat fades. So a petrous apex with a lot of marrow fat in it will look brighter on T1 than it will on T2. It's very simple ways to try to determine if you're looking at something pathological or something that is just normal. So this is the petrous apex here. Here you see this very dense bone that is surrounding a structure that has some membranes in it. This is the arc of the superior semicircular canal here. So this is just below the arcuate eminence. In the CT scan, you cannot see the difference between the endolymph and the perilymph, but in the histology imaging, you can. These are the mastoid air cells here. And this is Kerner's septum, or the petromastoid suture line. So lateral to this, so here is a simple lateral mastoid approach. When you get past Kerner's septum, when you get past the petromastoid suture line, you're now into the area of the antrum and into the area of the important structures of the temporal bone. So that was kind of easy. So as we go down, we're just going to do all the horizontal cuts, and we're going to go from superior to inferior in the same side. So now we've gone down a little bit further, and here you see the same thing with marrow. Here you see a little bit of marrow in that same structure. Here you see very dense bone. Like you can see that the white of the bone on the CT here is very different than the white of the bone anywhere else that you're seeing. And this is because otocapsule bone is the densest bone in the body. So it will look the brightest. It will be the whitest white that you can see on a CT scan. On the histology, you see that there's a super dense bone here, as opposed to this aerated bone that's a little bit softer in appearance or less dense in appearance. And then here you see a big area of air. Here you see a blood vessel. And here you see that this same area of air here, and then the mastoid air cells and the blood vessel. So what are we seeing here? This is, so I'm just going to go one before. So this is the superior canal, and it's going to come forward and it's going to come behind. So, right, it's going to come down into its arc. And as it comes to its arc, you're going to see the larger ampulated end of the superior canal, which is anterior, which is here. You're going to see the common crus, or the crus commune, here, which is the bony joining of the posterior and superior non-ampulated canals. The membranous canals do not join. So here you can see a separate posterior canal, separate superior canal, membranous canal. But on the bone, all you see is one big thing because it's got the two membranous canals inside. This is the posterior semicircular canal. This would be the subarcuate fossa, which is right here and coming out. And so this is actually a very common pathway for acute otitis media under the age of 6 months to go and become meningitis in a very short order. So this is the most common pathway for that. This is the attic or epitympanum here, and you can see it right here. And then this is the mastoid air cells. Back here is going to be the sigmoid sinus. as we go another layer further. So we're just going serially, inferiorly. And you can see on the CT scan, you can continue to see the apex here. You see this structure. You see very faintly this structure, which corresponds to that structure. You see this thing, which I just operated on a completely dehiscent one last week, and it took 8 years off of my life, but there it is. Here you see the vestibule. Here you see another structure with very dense bone. Here you see less dense bone. It's a slightly different stain, so the colors are different, but you see 2 little bones that are not as dense as this bone, and then you see some air cells. So what are we looking at? We're looking at the petrous apex up there, where this very faint thing that you see just anterior to the labyrinthine segment of the facial nerve is the cochlea, so the apical turn of the cochlea. This is the internal auditory canal. On a CT scan, you just see the canal. On histology, you see separately the facial nerve, the superior vestibular nerve, then you'll see inferior to that, the cochlear nerve and the inferior vestibular nerve. You see this thing, which the neurotology interest group will tell you, this is called Bill's bar, named after Bill House, the father of neurotology. It is also the superior crest of the internal auditory canal. So it's the vertical crest of the internal auditory canal. And what it does is it separates the labyrinthine segment of the facial nerve, the narrowest portion of the facial nerve, most prone to the site of injury, to be the site of injury in idiopathic or viral facial paralysis. It separates that, separates that from the superior vestibular nerve. So when you're approaching the skull base from lateral, you're doing your mastoidectomy, then you've made your island of bone and you've compressed the sigmoid sinus. You've come back here, you've identified the dome of the horizontal canal, you've identified the posterior canal, you've identified the endolymphatic duct, which is in this aqueduct. You're then going to keep going through the labyrinth because you're trying to reach the tumor that's here. And when you get here, you are protected from hurting. You're protected from hurting the facial nerve by this beautiful vertical crest that protects that labyrinthine segment. So you can get to here, peel the tumor off this way and out when you are approaching the facial nerve, when you're approaching the tumor and the internal auditory canal from the transmastoid or translabyrinthine approach. These 2 little bones that I talked about are in the epitympanum. This is the head of the malleus and the body of the incus. We are very much simpletons in the United States, so all my residents call this an ice cream cone. I don't find that that's very interesting, but the malleus is always anterior, the incus is always posterior, and you can see them here. You can see a nice sharp scutum or lateral epitympanic wall here, which is here. This is the additus ad antrum, so where the long process of the incus points to the opening to open into the antrum is called the additus. This is the dome of the horizontal semicircular canal. This is the actual membranous horizontal canal. This is the posterior semicircular canal. In the vestibule, you see the ampulated end probably of the superior canal coming down, which would be lit right here. So this is the vestibule. This is the horizontal canal. And then you see the endolymphatic duct start to emerge. And in this picture, you see the endolymphatic duct aqueduct. You see the bony aqueduct of the vestibular aqueduct. And this is the posterior semicircular canal. Ashima, you have to tell me if everybody's getting bored and leaving, okay?
Oh.
Just
No,
like
nobody's
this.
getting bored. We're loving it. The only thing is we're trying to increase because we already have 100 people. So we want to be able to get more people in. So we're just trying to increase capacity. Actually, we're running full capacity.
Oh, wow.
Yeah.
Excellent.
So I'm trying to fix that from the back end so that we can get more than 100 people to join.
Okay, can I just keep going?
Yeah, sure.
Okay, So now we're going to go one more level down. So we saw a lot of structures. If you think about this, look at what you're seeing on the CT scan. One of my mentors, whom I love dearly, was Professor Antonio de la Cruz from the House Ear Institute in Los Angeles, who unfortunately passed away quite young. But he,
complicated है तुम्हारा.
So he would say to me, because he was from Costa Rica, like I'm from India, and so when we learned English, we were each very particular about the words that we are using in English. And so he would say, Sujanita, don't say visualize when you mean see, and don't say see when you mean visualize, because you visualize in your mind, you see with your eyes. So on a CT scan, you see the structures that I'm showing you. When you look at a CT scan, however, in the vestibule, for example, you should visualize these structures. So you should visualize that superiorly in the vestibule, the superior ampulated end of the superior canal is coming down. The vestibular aqueduct is coming out. The utricle is going to come into appearance. You can't see any of those things on a CT scan. But if you know that these correlate, you can visualize what's happening inside the patient's body. So I think those are words that are actually very important to keep separate. So as we go further down, you see the horizontal level 4. This is an axial CT scan again. And what you're seeing here are these two ossicles are coming into very sharp focus. The scutum is quite sharp. You actually are seeing the top of the external auditory canal. You continue to see petrous apex, and this has marrow in it. And you can see that petrous apex here. You see this, which is this. You see that, which is much better in focus now, which is that. You see this, which is turning and coming like this, and you see part of it here. And then you see more vestibule, and you actually can see a canal going into this structure, and that is this canal right here. You can see sort of the tail end of the horizontal canal. You continue to see the endolymphatic sac, which is sitting under the operculum. The operculum is the piece of bone over the sac that protects the inner ear from the pulsations of the brain. So brain is pulsating here, and the sac, we are also not getting nystagmus every time our brain pulsates, because our operculum is protecting the delicate inner ear fluids from the pulsations of the brain. Here we continue to see sigmoid sinus, and here you're seeing more of the mastoid air cells. So, and then this structure here is the same as this structure here. So as we go down, again, not only do you see the bone of the canal, but on the histology, obviously, you're seeing the nerves inside the canal. On the imaging, you see the internal auditory canal, but all you can see is that there is something gray in there. You can't see any details of what's happening in there. Just anterior and lateral to the internal, to see the cochlea. And you see it really nicely here. I mean, in the histology, you can see the basilar membrane, you can see the spiral ligament, you can see the stria vascularis. If you zoom in, you're going to be able to see Reissner's membrane here. So what you can see on this is obviously more than you can see on this. Posterior and lateral to the internal auditory canal is the vestibule. And here you see the vestibule, but what you see, we previously saw the ampulated end of the superior canal coming in. Now we're seeing the ampulated end of the lateral semicircular canal coming in. So one of the things you should remember is that the ampulated end of all of the canals, are anterior. So the non-ampulated ends are all posterior, the ampulated ends, superior, lateral, and then posterior are all anterior. Here you see facial nerve as it's finished its geniculate ganglion and which is the first genu, and moving posteriorly along the middle ear to get to the second genu, which will be over here. In the image, you see actually a bit of the labyrinthine segment, the geniculate portion, and then the horizontal portion. You see malleus incus and you see scutum here. I'm going to just continue onwards because I don't want to waste a lot of your time and I want you to get to some dinner at some point. So here, I'm going to show you the next horizontal level. And the reason I'm not showing in a CT scan is that it's really very difficult to see this on CT scan. It's a very particular level of imaging that we don't subject patients to because of discomfort and radiation exposure. But here, look at the structures that you can see. So you're seeing the internal auditory canal, you're seeing the cochlea, you're seeing two of its turns come in. The facial nerve has already crossed the middle ear and is now turning into the second genu. The other horizontal structure that you see that is just below that is the bilobed tensor tympani muscle, which travels from anterior and then turns into the tensor tympani tendon at the cochleariform process. That goes to the neck of the malleus. The malleus is adjacent to the tympanic membrane, which is the end of the external auditory canal. This is the long process of the incus. Here we see facial nerve. We see the beginning of the oval window. So you're going to see stapes sitting in there soon. This is the utricle. This is the posterior semicircular canal coming up here. The cochleariform process is a beautiful landmark when you're dissecting from lateral to medial in the middle ear. If you have a lot of granulation, if you have a lot of cholesteatoma, a lot of inflammation in there, this will tell you where the horizontal structure in front of it is actually tensor muscle versus the horizontal structure posterior to it, closer to you, is going to be the facial nerve. So it's actually a very, very important structure. As we go further down, I'm going to go back to the imaging as well. And I'm going to show you this, but let me go ahead and put in the labels. So we've come further down here. And what you're seeing now is you're not yet seeing carotid artery on the CT imaging, but you are seeing it with a thin bone between it and the eustachian tube orifice, which is from here to there. So the bony eustachian tube. You're seeing tensor tympani muscle crossing. And, you know, when you're doing a eustachian tube balloon dilatation, it's very important that you do not insert the balloon past the isthmus of the eustachian tube, which is the junction between the cartilaginous and bony eustachian tube. It's very important that you don't do that because this very thin bone can be cracked by a balloon opening next to it. So you only do eustachian tube balloon dilatation in the cartilaginous portion of the eustachian tube. This is now you can see 2 3/4 turns of the cochlea. This is the protympanum here. This is the tensor tendon going to the neck of the malleus. Here's the incus. This is the tympanic membrane. Here you're going to see chorda tympani nerve here. This is facial recess. This is facial nerve, which happens to be dehiscent in this section. So if you're using a laser or drill to get to the stapes foot plate, you better be really careful because the facial nerve is in your and it's not well protected. This is the foot plate, and this is the saccule. So the membrane of the saccule, which is here, is less than 1 millimeter deep from the bottom of the foot plate. So when you're doing stapes surgery, your prosthesis should not enter more than 0.25 millimeters into the vestibule in order to be sure that you are protecting the saccular membrane, even in cases of high drops. So you want to be really careful that your prosthesis enters into the vestibule, but not more than 0.25 millimeters. And you can see these structures that are marked out here. The next section, I just love this section. My my Soder Mama, my mother's Soder Mama, my mother's brother was a big fan of Laurel and Hardy. And he didn't have a picture of any of our ancestors in his house. He had a picture of Laurel and Hardy in his house. And to me, this stapes looks like Stan Laurel. So I just I love this picture because it reminds me of my uncle. But this is again, I'm going to label it so you can follow along. External auditory canal. This is the tympanic membrane. This is the malleus. This is the lenticular process of the incus. This is the incutostapedial joint. This is the head of the stapes. This is the anterior crus and posterior crus of the stapes. This is the footplate of the stapes, right? That is sitting in this oval window. Here you see chorda tympani nerve in iter chordae posterior. So iter in Latin means tunnel. So the posterior tunnel of the chorda nerve. So iter chordae posterior. It flies in between the malleus and incus and goes out iter chordae anterior. So you're seeing actually the chorda tympani nerve twice here. You're seeing the facial recess air cell here. You're seeing the facial nerve here. And here you see the stapedius muscle going to the stapes. And then if this was this is the sinus tympani here, it will become more pronounced later on. This is sinus tympani, and here you see the relationship between the footplate of the stapes, the saccular macula, and the saccular membrane here. And you see a really beautiful picture of the cochlea and the internal auditory canal. And then as we go even further, we see now the external auditory canal, which has disappeared here. We see the entire basilar turn of the cochlea, which ends at the round window membrane, which is sometimes called the secondary tympanic membrane. This is a round window niche, which is the bony opening. The membrane itself is here, and the membrane of the round window membrane is always, I'm just going to see if I can show it to you better. It's always 90 degrees to the oval window. So this is the oval window, footplate in the oval window. And if you look at the orientation of that, look at the round window. So the round window is always 90 degrees to the oval window. So this can never be the round window membrane. There's a little adhesion over there, but you remove that, like to look at the round window when you're doing your cochlear implant, you want to make an opening into the round window membrane if you can. You can drill off the lip of the round window niche so you can get a very nice look. And then you're going to introduce your implant right here into the round window. This is the ampulated end of the posterior semicircular canal, right? So posterior is also inferior. All the ampulated ends are anteriorly. This nerve is the singular nerve, the nerve that comes off of the posterior semicircular canal ampulla. Dr. Gasik talked about doing a singular neurectomy for recalcitrant benign paroxysmal positional vertigo, which comes from the posterior semicircular canal. So what he talked about was elevating a tympanomeatal flap, coming sort of between the round window and the promontory, coming back here, drilling here, and lysing this nerve. It's very difficult to do. And frankly, you can make everybody better by shaking their head and doing a modified Epley or a modified Simon. So you don't have to do this. But in the laboratory, it's quite an interesting operation to try to identify the singular nerve transcanal in this approach. Here you see chorda tympani nerve, you see facial recess, you see facial nerve, you see stapedius muscle in the pyramid, you see sinus tympani, and then you're going to go towards round window. So this is sort of a 3, and that's the shape you should think about for the posterior wall of the middle ear space. And then here you see the 3 turns of the cochlea, and you can see clearly the round window niche here, which is this, and the round window membrane, which is very clearly seen because there's air in the middle ear. So this air to soft tissue interface is the round window membrane. So that's really important to look for when you're looking at images. sorry, what I did now. And then I think this is the last horizontal. Again, we're one step lower. And again, you're seeing round window niche, round window membrane. And here you see the beginning of the cochlear aqueduct. So this is your cochlear aqueduct. The cochlear aqueduct on imaging is about 2 cuts below and parallel to the internal auditory canal. The vestibular aqueduct is at right angles to the internal auditory canal and the cochlear aqueduct. So we are no longer seeing vestibular aqueduct here. This is your carotid artery, facial nerve, stapedius muscle, chorda tympani, tympanic membrane, and what remains of the inner ear there. And then don't forget the beautiful midmodular section of the cochlea and the organ of Corti. And maybe one day I'll just come in person and talk to you guys about that. And so I want to thank you so much for allowing me to share really my true passion. I love doing surgery. I love taking care of patients. I love doing leadership. I love recording podcasts. I love editing clinics. I love all of that. But this, which I was able to do with my dad, let's see, can you see me in it? Oh man, there, is the book. And it's set up just as I said, like so. And it's just super cool. I love this book. And I really am grateful to you for letting me share. Follow me on social media because I'm usually kind of interesting and sometimes kind of funny. That's it. Oh, I wanted to tell you guys, I am the publisher, consulting editor for otolaryngologic clinics of North America, which I'm so grateful, Dr. Poonam, that you think it's really good, because I do think it's really good too. In 2017, I introduced a podcast per issue where I interview the guest editors of the issue on the subject, and it's really good, and it's free to everybody. And I think it's a wonderful way to acquaint yourself in depth with whatever subject the clinics is covering. Like, for example, the picture that I show there is the issue on thyroid and parathyroid disease. And we just had I'm an otologist. I think I still have my thyroid and parathyroids, but that's about it. And but I learn a lot every time. And so I'm very grateful for being able to share information in that manner. And then you had asked about my show. We did 59 episodes from June of 2020 to December of 2021. They were weekly shows. They were so much fun. They covered the breadth of medicine, including dentistry, including physical medicine and rehabilitation. We covered COVID because this was in the height of the COVID pandemic. So trying to share as much information as we could, interviewing really interesting people about what they were passionate about. You can find it on YouTube. I'm hoping somebody has contacted us to see if we can resurrect it, and I really hope that we can. I think we teach in different ways, and using modern technology to teach globally is really interesting. I'm very grateful that I live in a time when we can do this.
Thank you, Dr. Sujana Chandrashekhar, for wonderful talk. I think this is out of the world, something which we don't come across. All the pictures which were mesmerizing, as mesmerizing as you are. So it was wonderful. I think you can see the comments in the chat. We didn't get so many comments after a talk as we got just now. And it was so wonderful to hear from you, and thank you so much for sparing time for us. It was really good, and I think I have not seen such beautiful pictures of ear, which were correlated with radiology, and I think most of us will agree with me there. So there might be some question. I'll ask Ashima if she can read them out or we can ask them question if there are any. And again, I thank you on behalf of WAOI for the sparing time. And I like to comment, you are so beautiful. And we are feeling proud as Indian for your achievement. Thank you so much.
Thank you. That's so kind of you. It's very kind of you guys in the chat. I really appreciate it.
By the way, I'm Dr. Chanchal Pal. I'm General Secretary AOI, residing in Delhi, attached to Apollo.
Oh, very nice. Very nice to meet you. Very
And
nice.
I worked in, yeah, please.
It's very nice to meet all of my sisters, you know, from home. It's very nice.
Yeah. And I worked in Manipal, so I have a special affinity to Karnataka people. So thank you so much again. Sorry guys for being partial there.
You can take the girl out of Bangalore, but you cannot take the Bangalore out of the girl. I'm as nutty as all Bangaloreans.
Great. Thank you so much. Over to Ashima, please.
Thank you very much. So, ma'am, the biggest question is, when can you speak to us again? I think that's flooding the chat history the most. Somebody wants more about pathology. People want more on the inner ear. So I think that's the biggest question right now. And then there's a lot of praise for you.
Well, thank you. That's so nice. We will coordinate offline. If you're interested, an area that I think is really ignored because it's very complicated is vestibular dysfunction. And you know, I think there's a lot we can do with patients who are dizzy. I think we can really help them. I think there are different ways to approach it, and it's with understanding the anatomy and the physiology and the pathophysiology of the vestibular system. So if you guys are interested, I'm really happy to share my ideas and learn from you as well. And I think that's an evolving area where we don't, you know, we have cochlear implants, we have stapes, we have, you know, we have a lot of stuff we can do. But sometimes there's the more challenging patients we find challenging because we don't really know how to approach systematically. And when you approach these patients systematically, like you approach a CT reading systematically, you can help them.
That's very true.
I think we love that.
Ma'am, one more question. If people from in here would want to like come and work with you, observe you for a few days, would you be open to that idea so that, you know, we can use this platform for very good networking as well? If you'd be open to that idea, if there is route that they could write to you or something.
Yes, absolutely. So I think you have my email, but I will I'll put it, or just WhatsApp. Just give them my WhatsApp information. If you guys flood me, I'm gonna block all of you. But if you keep saying like there's another group that has way too many posts, but no, happy to, and I will tell you the AAOI, which is the American Association of Otolaryngologists of Indian Heritage, meets every September at the AAOHNS meeting. This year it's in Miami, but we offer scholarship for people who want to come to the meeting and then do an observership for some time, either before or after. So if you look up the AAOI or AAOIH information, and I will also try to find it and send it so that you can share it, but those scholarships are available and we want to give you the money. So we want you to come to the United States and we want you to come to the meeting and we want you to spend some time shadowing, and it doesn't have to be just one person. It can be, you know, I want to shadow this person in otology, that person in rhinology, whatever.
Great.
That's a great information. Thank you so much. I heard your facial nerve webinar monitoring, and then I just could not help but reach out to you and have you speak to us. So I'm so glad this all materialized. Thank you so much.
Thank you. Yeah, we've done 2 really nice webinars from the American Otological Society. One was on innovations, and actually Deepa Galaya, who is at Hopkins, also a younger sister, would be a terrific person to speak to your group. Her understanding of new technology in otology is outstanding. But she was one of the speakers on the first one, and then we just had one on facial nerve monitoring, which I thought that I get to moderate them, so I just get to listen to the speakers, which is really fun. but they are both available on the American Otological Society website for free. So AmericanOtologicalSociety.org, I think. Very happy if you view those offline. I think they're wonderful educational tools.
Great. I think we will contact her too.
Yeah, she's terrific. You'll really like her. Watch that first webinar, you'll see.
Good. Ashima, anything
So
else?
thank you very much, Dr. Sujana. Kindly share her number as well. We will definitely invite her for the next lecture. And yes, what could be the waiting period in case somebody is interested in coming, taking up a visiting fellowship under you?
So if they want to come via that pathway with the AOI grant, that would actually be in September or October.
Yeah, that I understood. Yeah.
Yeah,
Apart from
but
that, if they want to come directly.
anytime. If somebody's coming and my offices are in New York City and in New Jersey. So a lot of people have family out here. So even if you're visiting and want to stop in for a day or two, I'm very happy. I just have to get some detail, like a week or two before,
Sure.
some details of like, you can't have tuberculosis, you have to have whatever, like there's some few items that you have to check off, but
Right.
that's okay. Yeah.
It's very kind of you to offer that. Thank you. Because, sometimes one of us would be traveling there and maybe we could drop in at your center and just observe for a day or two. It's so nice to listen from you and really appreciate your time and effort and, very impressive presentation. You are truly inspiring. I mean, way to go. You're still very young. And yeah, I don't know what to say, we're short of words, like you are indeed very great. So a lot of people can follow your footsteps.
Well,
Thank you
very
again.
much.
Thank you once again for this lovely lecture.
Thank
And
you.
we'll bother you again for vestibular talk, definitely.
Absolutely. My pleasure. My pleasure.
Thank you so much.
Take care. Thank you again very much.
Okay, so we conclude this
evening with your
session since there are
family.
no more questions for you. Thank you.
Take care. Bye-bye.
Bye. Thank you so much. So there are two more upcoming talks. I'd like to announce if the people are still around. One by Dr. Anita Swalone from UK, and one from our own Dr. Renuka Brado from Mumbai. So we'll announce the date soon and the topic also. I think I should thank everybody who's was in process of organizing such a wonderful talk. Thank you, Ashima. Thank you, Kalpana and Abha and Sharmila for that. And thank you all the audience for being there. I think we have done more than 100 people listening today. So it was wonderful. Over to you, Kalpana.
Thank you, Dr. Chanchal. Thank you so much for everything. And your experience counts. You keep advising us on various things. And thank you, Executive, once again. And thank you, all the members, for trusting us. We'll keep going. Thanks for all the encouragement. Thanks for those encouraging words you write on the WhatsApp group. Thank you all. Good night.
Good night.